А далі ми будемо слухати наступного спікера. Спочатку запис, а потім у нас буде 10 хвилин, щоб ми змогли задати запитання в онлайні. Тому прошу до слова Ліза Вальгрен, дипломована фізіотерапевтка та аспірантка, яка спеціалізується на м'язовій дистрофії Дюшена та функції дихання. З темою «Життя з м'язовою дистрофією Дюшена у Швеції», національне дослідження стану здоров'я, респіраторної допомоги та тривалості життя.
Hi. First, I would like to thank you for the invitation. I am a physiotherapist and I've been working with pediatric care with neuromuscular disorders during the last 15-20 years. And this has been a time where life expectancy for individuals with DMD has been steadily increasing. And the question that arises is now, how can we provide the best care, especially at the right time, to ensure the best possible outcomes over a longer lifespan? And to gain some deep understanding about how it is to live with DMD as an adult, we initiated this project in Sweden with a focus on health status, respiratory care, life expectancy, and cause of death. And to give a brief background for the project, I just will start by providing an overview of how lung function is affected in individuals with Duchenne. I understand that respiration and respiratory intervention has been a topic of this conference and has been discussed here earlier. So just as a short summary to put the project in context. Regarding lung function, the respiratory muscles are affected, both the inspiratory muscles, which helps to expand the chest to allow deep breath, and the abdominal muscles, which provide force during exhalation, such as when we need to cough to clear the airways. The main issue with respiratory function in DMD is insufficient air volume due to weakness of the respiratory muscles and reduced chest wall compliance, together with the inadequate force to clear the airways due to weakness of the expiratory muscles. The diaphragm begins to weaken around the age of 10, and we can see an altered breathing pattern by the age of 14-15 years of age. Later on, we can see a reduced tidal volume and a reduced minute ventilation. And it's around this time, around transition to adulthood, we also see that non-invasive ventilation often is initiated. The abdominal muscles show a clear impairment in the early teenage years, and assisted cough is recommended when the ability to cough is limited. We know that improved care with glucocorticoids, assisted ventilation, cardiac protection, and scoliosis surgery has had a positive impact on life expectancy and the course of the disease. And gaining insight into the long-term outcomes and mortality patterns within this population is important, both for developing preventive strategies and for managing emerging comorbidities as individuals with DMD grow older. And there are limited studies on evolution of natural history regarding adulthood with DMD and comorbidities. So in this PhD project, we conducted two separate data collections. The first two studies used a retrospective approach, meaning we looked back in time. In study one, we investigated the prevalence of boys and men with Duchenne, life expectancy, and cause of death. In study two, we used the same data set. We focused on identifying risk factors for respiratory failure. And in the third study, which is nearly completed, we focused on the current situation for adult men living in with DMD in Sweden. And here we looked at motor function, assisted ventilation, and how these relate to perceived health. In the fourth and final study, where data just has been collected and we are starting to analyze soon, we aim to understand how lung function and respiratory interventions affect key aspects of daily life, specifically fatigue, pain, sleep quality, and overall quality of life. first two studies, we aim to identify all patients born, all boys and men born in Sweden from 1970 and onwards with a confirmed diagnosis. And by using sources, the sources we used to identify the study population was all pathology laboratories performing muscle biopsies. We contacted the registries, the Swedish Registry of Respiratory Failure and the National Quality Register for Neuromuscular Diseases in Sweden. We also contacted all neurology and respiratory clinics in Sweden and asked them how many patients they have had since 1970 and onwards. And then we looked, the data collection was to identify who was alive and who was not alive. We used the cause of death registry and we used medical records for data collection. In the third and fourth study, we only included patients about 18 years of age, and we used the National Quality Register for Neuromuscular Diseases in Sweden, and we also invited patients that were followed at our neuromuscular center here in Gothenburg at Sahlgrenska University Hospital. And all patients conducted here a survey. And the first study was published in 2022. 1 in 5 patients with Duchenne muscular dystrophy dies from other causes than cardiac or respiratory failure was the title. In this study, we were able to identify 373 boys and men diagnosed with Duchenne muscular dystrophy. All in Sweden, all born in Sweden from 1970 onwards, but it was particularly challenging to trace patients born in the 70s due to limitations in historical data. Because of this, we needed to exclude the patients born in the 70s from the life expectancy analysis to ensure accuracy. Of the 373 individuals, 129 individuals were deceased. And at the time of data collection, we found 130 individuals alive, above 18 years of age in Sweden, which was giving a point prevalence of 3.2 per 100,000 adult men. At the time of this study, there were more adult men than boys under the age of 18 identified living with DMD in Sweden. It was 130 patients versus 114. And to put it in a broader context, there is a Danish study published in 2024 by Rudolfsen and colleagues, and they reported a roughly 70% increase in prevalence of Duchenne over the past 2 decades. This highlights a significant trend in improved survival and diagnosis, which we also see in Sweden. Okay, regarding life expectancy, the median age of survival was 30 years in our group, and notably 25% of the retrospective cohort lived beyond the age of 35. In this survival analysis, all patients born between 1980 and 2000 were included, and patients alive at the end of this study was censored. We also looked at the loss of ambulation, and it was typically around 10 years of age, and analysis didn't show any correlation with overall life expectancy, that the age of when you lose ambulation could predict that. So this result reflects significant progress in clinical care and management over the years. It becomes increasingly important to understand and manage the prevalence and burden of comorbidities in adults. We also looked at the cause of death, and respiratory cause of death used to be the most common among individuals with DMD. However, with the introduction of assisted ventilation and a more proactive approach to managing respiratory comorbidities, not only has the life expectancy increased, but respiratory and cardiovascular causes of death have now become nearly equally prevalent, with close to 40% of the cases in each. Death from cardiac complications occurred later compared with other causes. Improvement in respiratory care and as well as cardiac protection are major contributors to this shift. However, 1 in 5 patients in our population died from other causes, and these patients were significantly younger. We had 21 at the age of 21 versus 25 years of age. And the causes of death identified in this population was infection, stroke, injury-related pulmonary embolism, gastrointestinal complications, and unnatural causes. In the second study, we focused specifically on the 129 patients who were deceased in order to examine long-term outcomes and mortality patterns within this population. Despite the evolution of respiratory care, respiratory insufficiency still accounts for approximately 40% of primary causes of death, as we presented previously. The aim of this study was to explore the respiratory-related comorbidities and the potential effect of these comorbidities and associated treatments on life expectancy and causes of death. So if we look at the clinical events, we saw in our study population that the median age of first pneumonia was approximately 17.8 years. We observed that 70% of the individuals had experienced at least one episode of pneumonia during their lifetime. More than half of these individuals had had the first pneumonia before hypoventilation was confirmed, suggesting that pneumonia may precede or even contribute to the identification of a respiratory insufficiency. And we also looked at the respiratory-related interventions, and this timeline illustrates the ages at which key respiratory interventions were initiated, including assisted ventilation, mechanical in- and extubation, and tracheostomy. The median age for starting assisted ventilation was 19.3 years, with a median time of approximately 4 years from the initiation to needing over 16 hours of assisted ventilation per day. MIE was used by 44% of our population, and at an age of 20.3 years. But when we looked at the more thoroughly into this population, knowing that MIE was introduced in Sweden in 2005, we could see that patients born in the 80s had an older age for initiation of MIE, and the difference was 23.4 years in the 80s, and for patients born in the 90s, it had been reduced to 17.4 years. We also looked at the impact of clinical events and treatment on life expectancy. Acute respiratory failure accounted for 63% of all respiratory-related causes of death. Scoliosis surgery had no effect on life expectancy compared with patients with scoliosis not treated with surgery. There was no difference between these two groups regarding age at start of hypoventilation. The presence of pneumonia and untreated scoliosis significantly increased the risk of dying from respiratory-related causes. Pneumonia was also a major cause for unplanned hospital admissions during the last year of life. In contrast, undergoing scoliosis surgery showed a protective effect against respiratory failure, although this finding did not reach statistical significance. Patients who received assisted ventilation had a higher life expectancy compared to those who were not treated. These findings underscore the importance of early identification of subclinical hypoventilation and the need for active treatment strategies when clinical signs of pneumonia appear. Non-invasive ventilation has been shown to relieve respiratory muscle strain and reduce daytime dyspnea. However, poor sleep quality is frequently reported among patients receiving NIV. Since sleep quality is a known predictor of health-related quality of life, this is an important consideration. While decline in motor function is associated with negative impact on health-related quality of life, the disease is not solely defined by muscle weakness, functional disability, and respiratory insufficiency. It also includes scoliosis, gastrointestinal complication, and neuropsychiatric symptoms, all of which contribute to reduced quality of life. So, the aim of this study was to characterize and identify association between functional ability, ventilatory support, and perceived health. And we also conducted an in-depth evaluation of motor and lung function, as well as comorbidities over time. The in-depth analysis were made on the patients follow-up at Sahlgrenska University Hospital, only including 19 patients, named subgroup here in the results. And the unpublished study is called Living with Duchenne Muscular Dystrophy as an Adult, Motor Function, Ventilatory Assistance, and Health, and Self-Reported Health. And we looked at the motor function, and we used the DMD-SAT. It's a patient-reported outcome functional scale used in a national survey. It consists by 8 items describing level of activity in arm function, mobility, transfer, and ventilatory support. Since it's an adult population, I found the arm function most interesting to present here today. So you can see here on the picture, 13% could lift their arms above shoulder level, 34% could eat and drink independently, and 47% were only able to use the fingers or less. And this was on the 63 adult patients that participated in the study, with a median age of 27.4 years, so with a range of 21 to 34 years of age. In the subgroup, 7 patients were followed over time with motor function measure that we were made at their clinical follow-up at the Sahlgrenska. The follow-up period was 1 to 2 years, and we could see a significant decline in the upper limb function between the first and the second assessment in the axial and proximal function. Our study showed, we looked at the perceived health compared to age and the motor function, and we showed that neither upper limb function during the adult non-ambulatory phase of DMD nor age were significantly correlated with patients' perceived health. Interesting is we also saw the patients who had an optimal use of assisted ventilation at night, combined with a few hours of use during the day, tended to report better perceived health compared to those using ventilation less, only nighttime or less, but also compared with those using requiring full-time support, being more attached to the ventilatory support. But this trend did not reach statistical significance, since we might have too few in our population. So, as a summary of this presentation, we can see that the patient with the population is growing. 1 in 5 patients die from non-cardiopulmonary causes, but respiratory failure and cardiac failure remains the leading causes of death. We could see that pneumonia, first pneumonia, and untreated scoliosis significantly increase the risk of respiratory failure, but that assisted ventilation is linked to higher life expectancy, while scoliosis surgery showed no effect on life expectancy. We also saw that age and motor function did not correlate with perceived health. Optimal use of ventilation may improve perceived health, though not statistically confirmed. I just want also not presented in this presentation. We are about to publish a new paper on severe, less common comorbidities, not respiratory comorbidities. We just got it accepted. And we're also working on the lung function and respiratory interventions and the key aspects of daily life, which we will hopefully be able to present some more results by the beginning of next year. So thank you for your attention, and I'm here to answer question if you have any.
Дякуємо пані Лізі за її доповідь.